make it reality. And if you work together with other people, you can make it reality. So moving back to the critically ill ARDS patient's multi-system injury, the pharmacist, as you know, on the Pharm.D, has to monitor this patient every day. How many days of antibiotics? Are the drug levels okay? Are the electrolytes fine? Is the nurse running out of this vasopressor? I need to get it fast. So technology can help you with this. So you start getting alerts, electronic alerts, which tell you that, say, for example, you're giving a medicine for many days, and the system will tell you, you know what, your medicine's been going on for too long, maybe you should stop it. So these kinds of clinical decision support systems are available in many healthcare records, electronic records, and all of these require smart people to think and adjust and kind of play a role in creating these. I want to switch now. We talked about a very, evolved, almost utopian system, which is existing. Very many developed countries, many hospitals in India which have high-level, advanced, tertiary, or even quaternary level healthcare systems have these things. But what about the rest of the world? What about the vast majority of people who don't have resources? Let's take a statistic which you might be aware of. There's about 70,000 ICU beds in India. Ask about 10,000 critical care doctors who are trained and specialized in intensive care in India. There's about 5 million admissions a year. And with the corona crisis, we've realized that ventilator training is not very well known. We've also realized that there is a huge shortage of many things in the healthcare system, but the biggest shortage is probably skill sets. And skill sets, the soft skills required to manage patients who are critically ill is not there. And all of this is available within our reach. If you can just look around, there are courses, there are training modes which you can actually do this. The other big numbers to think about in India, for example, 6% of people above the age of 60. In my view, that is probably why India has done reasonably well with the COVID crisis, because the number of people who are much older is not that high. But at the same time, 6% is a big number for India. It's about 72 million people. And according to the statistics released by the different various government bodies, in about 9 years from now, which is not that far away, you're going to have 150, the number is going to double, 150 million people who are about 60 years of age. And if you look at it, these are the people who are going to have comorbidity, diabetes, hypertension, kidney disease. They're all going to get sick, and many of them may be your relatives, your elder brothers, sisters, are all going to be in that age group and not too distant future. All of us are going to get to that age at some point, and all of us want to live a long, healthy life. And not all of us will be genetically privileged to not have diabetes or hypertension. We might have it, but it can be treated. And we are hopefully going to get newer medicines, newer things. They're going to make a difference in how you manage these patients. But the reality is that you're going to end up needing healthcare to continue. The number of people who are going to be sick is not going to decrease. The number of people who get sick, maybe we'll get newer systems of care, maybe genetic treatments, maybe we'll get all kinds of new ways to take care of patients, but healthcare moves at a relatively slow pace. Healthcare does move fast. There are some blockbuster drugs which transform lives. For example, in CML, you had the drug imatinib, Gleevec, which changed overnight how CML patients are taken care of. And then this whole new class of biologics has come. Now we're getting a whole new class of genetic drugs. Now we have these new forms of vaccines which are coming up, the mRNA type vaccines. So there's a whole bunch of new things which are coming up. But at the same time, many of these things are out of the reach of common people. Now, there is, as you know, one drug which treats spinal muscular atrophy, which costs millions of dollars, but one dose can transform the life of the patient. So the cost of drugs is obviously very high. Patients can't afford it. The average cost of a patient in an Indian intensive care unit, as per a study done several years ago, was about 17,000 rupees, but it's actually much more now. So if you look at the number of doctors, the number of healthcare providers, number of beds, all of these are short resource. So how do you kind of multiply this? Of course, you can use things like remote care, which I do, remote intensive care, and I'm monitoring patients remotely. People who have rotated with me know that we are actually remotely monitoring patients around the country and actually monitoring the drug lists of patients who are around the country. For Apollo Hospitals, we also do remote telemedicine for patients around the country. And every time we do that, we have to look at their list of drugs and look for drug interactions. A huge problem in India is that multiple brands are there for the same drug. And you can have very often drug duplication. I had a patient who's very sleepy and I'm trying to figure out why. Turns out she's on a drug that is an anti-allergy medicine which has H1 blocker, an H2 blocker. You also have a drug which is a kind of a stronger like a sedative, and you have all these things are duplicating themselves in cough syrups, etc. And the patient is very sleepy and drowsy, and I'm like, you know what, this is not the way to do it. So we had to cut back and tear back. And also, there is this general kind of a community thing that if you don't get medicines, you're not getting treated. So there are a lot of implicit bias in terms of the patients also who think that, oh, you know what, if you don't get 10 medicines, I'm not getting it. So there's a lot of perception change that needs to happen. There's also a need to practice evidence-based medicine, and there's also a need to face ethical medicine, because a lot of times there's a lot of interaction which is not very present to you, that when you order a medicine, somebody is getting something somewhere. So these are unfortunately the realities of medicine, not just in India, in many countries. It's important for us to try to dissect away and come back to the point that, patients are actually needing this because they're not choosing to have this. They are sick and they need it. So we need to make sure we give them a evidence-based ethical practice of whatever we're giving them. So we've talked so far about a critically ill patient, multi-system involvement. We talked about the role of the pharmacist in each part of the system, and I'll delve a little bit deeper into that. And we also talked about a little bit of the philosophy of care that I think is the way to do it. We talked so far about the statistics of why we actually need people to get involved. We're running at about 30 minutes already, so I'm going to kind of switch gears here. I'm going to start giving you some ideas of how to actually make a difference. Now, somebody once told me, Sai, you have all these good ideas. Why do you keep giving them away? You can kind of make a lot of money if you kind of push these. I think you're right. I mean, of course, I could make a lot of money if I actually push these ideas through it. And partly because I just have so many ideas, I don't want to just one or the other. But somebody else told me, give your ideas away because new ones will always keep coming. If you give things away, new things are going to fill their space. Give away things so that you get things. Always keep your hand positioned this way so you're giving, because you will keep getting. I think it's important that we keep that idea in mind, because the more you help people, the more things will come to help you. I believe in this concept of the universe always trying to help you with what you want to do. And I've seen it in my life, and Karthik has seen it. If you actually do things which are right, people will always be there to support you. One of the things I was thinking of is, okay, so one of the ideas is, say, for example, a patient is on blood thinners. Take the COVID crisis right now. People are often on blood thinners. They're getting discharged on blood thinners, but not everybody is clear exactly what blood thinner to use, exactly how long, how should you use it. There are very good guidelines. For example, the American College of Chest Physicians have guidelines on how to treat DVT, pulmonary embolism, and other kinds of anticoagulant requiring medicine. Overseas and some places in India, you have anticoagulation management clinics, but I'm not seeing that on a regular basis. Patients who have heart valves, patients who have DVT, patients with atrial fibrillation, patients with pulmonary embolism, all of them need their anticoagulation managed. Here's an anecdote. I was in the US and I worked in a small town, and there was a patient who saw me on Friday evening, and there you have the weekend is off. I was working that Saturday, and they gave blood to check their INR, and because they're on warfarin for their atrial fibrillation, they checked their INR. The report, unfortunately, this is a small town, so they didn't run it right there. They had to send it away. The blood report came back that next day, Saturday afternoon, and the INR was 9. Now, 9, as you know, is very much higher than the goal you want of 2 to 3. 9 is a level where if you hit yourself and bleed, it can be dangerous. And unfortunately, since it's a weekend, they couldn't figure out who the patient was, and they called me and said, this is the result. You ordered the test. Here's the result. You deal with it. I had no idea how to reach this patient. It's a small town. So I had to do a lot of juggling around. So what did I do? I called the pharmacy which prescribed the medicine. Pharmacists in the US actually have these names of patients and their numbers. So they gave me the number to the patient. I called the phone number, but it turns out the patient is not there. They had left their phone by mistake, and those days they had these cell phones which are clunky, so they didn't carry it with them. And this is a town which is in the winter. It's actually in North Dakota, which is extremely cold, and people are always bundled up in homes. So anyway, I called this number, and somebody picked up and said, "Oh, they left their phone." So I said, "Okay, where did they go?" They had gone to a wedding 300 kilometers away somewhere, and I'm like, "Oh my God, what do I do now?" I asked them, "Okay, where is the wedding? Do you know who went with them?" They said, "No, we don't know." And they asked, "Okay, who's getting married?" I said, so I Googled it at that time, at Google, and found out that this wedding is going on in this church in this place. I actually called the church, spoke to the pastor there and said, "Hey, I know you're getting these two people married in some time, but one of the people attending this wedding has a very high INR. Can you tell them to go to this hospital? And the pastor was very kind and said, yeah, sure. So before this wedding started, within 15 minutes, called out to this patient who was in the audience and said, hey, come along here. You can't stay in this wedding. Please go to the hospital. So he called an ambulance to the church and then actually went and took this lady to the hospital. And, INR is high, so there's your vitamin K and all that. So, I mean, if you really want to make a difference, you can. So one of the roles that the Pharm.D can play is interact with patients, understand their medicines. There's a lot of illiteracy with healthcare. There's a lot of illiteracy among patients. Patients don't take the medicines on. All of you don't. I don't. People we know don't. Now, one of the take-home messages today for you, all of you, to do today is take a sheet of paper, type it up or write it out, get a hold of one or two elderly family members of yours, get a list of their medicines, write down the brand name of the medicine, chemical name of the medicine, dose, when to take it, why are they taking it, who is the doctor who prescribed it, how do you get a hold of them? Check and see, do you need to make any difference to this dosing? Do that today. That's a take home for you. It's a homework for you today, for you to actually do that for your family, so that you have a typed list which tells you, oh, you know what? These guys are getting 2-3 drugs which they don't need. Why are they on this drug? Are they checking if they're on, say, a medicine like hydrochlorothiazide, are they checking their potassium and sodium on a fairly, regular basis to make sure that's not low? Oh, they're on a diuretic and they're on a potassium supplement. Oh, they're on a potassium sparing drug and they're on potassium supplement. A lot of interaction. And in fact, Karthik, it would be wonderful to see if out of this exercise, anyone picks up something that's of interest, so you actually make a difference. Message Karthik back, so you can message me back, and then we can take it from there. And by the way, my Twitter ID is @thinkmd, THINKMD, so you can kind of direct message me if you want with that information, and can let me know about that. So we've talked about several things. I give an anecdote about the INR. And so what is the critical role of the Pharm.D in intensive care in India today, or actually anywhere in the world? It's right now not very existent. You have to create that role. So I'm going to switch to a kind of a prescriptive type of talk now, where I'm going to tell you suggestions of what you could do. Now, I know that Pharm.Ds are trying to find a place, a role, in terms of how to fit in the healthcare ecosystem. One of the things that you need to look at is the team effort. You've all heard what team stands for. Together, everyone achieves more. And I was thinking yesterday about this. The thing that came to mind was, let me just see, I made a note of this. Together, everyone achieves miracles. That's the analogy that came to me. I know everyone achieves more, but together, everyone achieves miracles. If you can actually work together with a healthcare team, you can make a difference. The other huge concept that comes to mind is, if you can, if you can lead without titles, you can achieve a lot. And it was one of these, I forget the famous person who said it, but they actually said, if you don't care who gets the credit, a lot of great good things can be done. So if you can actually position yourself in a place where your title doesn't matter, it's important, but it doesn't matter. The outcome of what you do matters, then you can actually get a huge role to play. And I think that's a concept that we need to start thinking of, where even though you get this title saying, I am this, this, and this, if you can show that you can make a difference, your value and your worth will be immensely evident, and that will be a way to transform the role of Pharm.D, in my opinion. Now, that will involve collaborating with doctors who have MD pharmacology, people who have B Pharm, M Pharm, other Pharm.Ds, nurses, and health administrators. You have to think, can I position myself as a part of the team whose only outcome is change the care of the patient, get the outcome of the patient better? I'm a part of the healthcare team. I know my title matters. I know I need these other peripheral things which are important for me to recognize myself as a professional. But at the same time, can I begin the work of getting things done? This is something I thought I should share with you all, because there is a huge need for people with your training and your caliber and your thinking to get into the healthcare system. Now, getting into the healthcare system may not be an open door that people just say, come work for me. It might involve yourself positioning yourself where you make a difference as perhaps a hospital-based pharmacist, a research pharmacist, perhaps a researcher in a healthcare infrastructure, or maybe even in a large online pharmacy where you're guiding people what needs to be done. Perhaps you can outsource your work for other countries. So there is several ideas you can think of. See, along with the day-to-day work of checking for drug interactions, making sure that drug levels are appropriate, making sure there is no drug duplication, making sure that the patient is getting the most cost-effective treatment, ensuring that there is infection control practices of stopping antibiotics are required, especially in patients with sepsis, monitoring the drug levels and adjusting the levels of, say, albumin, replacing and adjusting electrolytes as needed. These are all the day-to-day work of pharmacy graduates. It might also involve things like calculating creatinine clearance and ensuring that you're measuring the drug doses which are appropriate. And of course, also ensuring that the doctors and the healthcare team is aware of newer treatments which are coming up. Any disease, asthma, COPD, antibiotics, whatever it is, making sure that these things are coming up and people are knowing about it. Also trying to doing all of this ethically, because you're going to pull left and right by companies who are trying to make money, who are trying their best to sell their product. I'm not going to blame them, but at the same time, we have to realize that 800 million Indians live on $2 a day. 800 million Indians live on $2 a day. 80% of healthcare in India is private based. People can't afford this. Now, one of the things which really, really bothers me is you get a patient in a hospital, they have a fever, 100, 101. Left and right, people are giving them intravenous acetaminophen. Why? People can take orally. Temperatures will come down in an hour or so. You can give acetaminophen or paracetamol as an hour comes down. There are, of course, rare situations where you need to get the temperature down very quickly. Of course, sepsis, you have to get the temperature down so you don't get worse outcomes. People with malignant hyperthermia, you need to get the temperature down very quickly. There are surface cooling methods, but left and right people are using it. Let me give you an example. The cost of each of these one vial is perhaps 100 to 200 rupees. You end up giving them 3 times a day. That's right away 600 to 1,000 rupees. This patient is here for 7 days in the hospital. 7,000 rupees of acetaminophen, where you could have done away with the 100 rupees worth of acetaminophen. Think about that. Now, when you don't think about the cost of care to a patient because irrational care, you're doing a disservice to that patient. It's very important we figure out how do you balance the commercial need of running a healthcare institution and a healthcare business with the reality of the ethics as well as the inability of patients to really afford these things. That 7,000 rupees might have meant that this is a transformational amount of money for this patient and his family to get their kid to school. We don't think about it. Think about infection control. People don't wash their hands. They end up with multi-drug resistant infections. They don't wear gloves when they're handling a patient. They end up giving them high-end antibiotics where a single dose costs 7,000 rupees. They need it 4 times a day. It's about 25,000, 28,000 rupees. They need it for a week. Think about that cost. Think about what that really means. This is perhaps the earnings of somebody for a year. So we have to step back and say, okay, there is a theoretical basis of my knowledge. There is a practical application of my knowledge. And what is my role in society to apply this? And I like to integrate this because ultimately we're all social beings. You need to make a difference as a healthcare provider. People trust you. People rely on you to make a difference. People are believing what you say. So whatever you say needs to be honest. Your words need to be truthful. And you need to make sure that what you're saying is going to make a difference to the patient. So again, as a summary to people who might have joined late, we talked about what is the role of a Pharm.D in critical care. We talked about my story of how I understood about it. I gave you some anecdotes of how you can apply this knowledge in various aspects of organ system-based diseases where a Pharm.D makes a difference. We talked about the advances in care, including clinical decision support, artificial intelligence. We talked about ways to actually use pharmacy knowledge to transform. Now, I will later on share with you several articles. I had a colleague in the US, she's a Pharm.D, critical care specialist. She sent me many articles on the details of how this can be done, and exactly 3 good articles. I'll send them to you. And I wanted to kind of talk about these things. And we're at 48 minutes or 45 minutes of the talk right now. And I'm going to kind of close off, just 4 or 5 minutes and then invite questions and we can keep talking about this. There's only one other concepts I want to talk about. And one of them we touched on was the team-based effort, so that you can insert yourself in a team and also make a difference to your own families in terms of how you're practicing the critical role that you're playing. Compassion is critical to critical care. You have to realize that when patients are in the ICU, there is a huge amount of stress going on. Providers, the nurses, the patient's families. And as a Pharm.D, you can expand your role. And when the patient's families are there, perhaps you can talk to the patient's family and find out what medicines were they on before. What are the medicines they need to go on after they go home? You can also look at perhaps the family members, and especially in the COVID crisis, you may have multiple patients who are infected. And there may be many family members who need help for doing this. And doctors and nurses can't do this all the time. You may have to play a role. You might have to interact with others and come up with a way to do this. When people train with me and rotate with me, I also have to do two other things. One is when you're teaching somebody a inhaler use technique, do it correctly, because most people don't know how to use this, for example. But there are other things which need to be taught to patients, which are a practical necessity, where timing of medication, take it before treatment, when do you take it. There's also a role of observation when you go have a pharmacist prescribing medicine. Unfortunately, now you just write it and give it to them and they go. But there's a need to explain to them, how do I take it? So these are all things which need to be done. There are not enough people to do it. And a lot of times people are ordering medicines online and they have no idea how to actually take these things. And I think it's important that as a role, you can play a bigger role in educating people how to take these medicines. So very specifically in critical care right now, the Pharm.D can become a central point of interaction to look at all the medicines the patient is taking before, after, and during the hospital stay. You can look at creating a system of new services. Now, somebody told me a couple of days ago, I was listening to a podcast, and it said an entrepreneur is somebody who fills gaps. An entrepreneur is somebody who fills gaps that nobody else saw existed. So you're all entrepreneurs if you can realize, you know what? I'm rotating and there is nobody to tell the doctor that the dosing of these medicines can be changed very easily. There are many apps out there, many things you can use to actually do this. And perhaps you can look at your own environment and say, this is a gap that needs to be filled. You can offer your services to a pharmacy group in your area and say, you know what, I will do prescription audit commercial pharmacy. You can do these things. You can actually do on a real-time basis starting today. And I gave you that homework exercise. I'm hoping all of you are going to do it today. Today is the 10th of January. There's only 355 days left for the year. And you're already going to be in 2022. Last year went by like this. And we all know that time is running away from us. Even a 100-year-old only lives for 365 days times 100. That is only 36,500 days. It's not a lot of time. But every morning when you wake up, you are given 86,400 minutes. Keep these 86,400 minutes and do what you want with it. Every human being who's ever lived, and there's been about 100 billion human beings ever lived on planet Earth, they all had every day, the start of the day, this many minutes. And some of them transformed the world. Some of them lived their lives. Didn't do too much that transformed everybody else, but doesn't matter. But each of you had to transform your lives of people around you, and the fate of the world. If you can just think about, how do I make a difference? We all have our strengths. We all have our weaknesses. And it's important that we recognize that and try our best to kind of keep our ego in check, because all of us have a lot of ego. How do we actually get the ego out of the equation when you're actually trying to take care of patients? Because in healthcare, not just in India, everywhere, the ego plays a huge role. You may come across healthcare providers who don't want to listen to you. So you want to think and say, okay, how do I make a difference? How do I dance without stepping on toes? How do I make sure that this is applicable? And this is where you need to think about how to make a difference where you're not personally impacting somebody. How do I take care of somebody else's patient care needs without impacting what they are going through? These are things which require thinking, where you can actually make a difference without affecting the other person. And this is not going to be easy. They're not going to be easy answers. And this is something where I feel very strongly that collaboration works. The other thing to also think about, which I've seen in some of my slides I've shared before, is learning, because life never stops teaching. Every moment of every day, you're learning more and more and more. And I like to compare astronomy and healthcare, and I like to compare aviation and healthcare for a couple of reasons. I just love just thinking about those things. If you look up on a clear night, you're looking up at the sky, there is nothing between you and infinity. Absolutely. You just keep going out in space. There's nothing between you and infinity. And our role in time and space is minuscule. You've all seen a picture of the spacecraft that went past Saturn, and then they made the camera turn around and look at Earth. You're a dot. Everything that ever happened in human history happened on this little tiny piece of rock. They're all sitting on it. And in 100, anything we do today matter? And that's the question to ask yourself. In 100 years, will this really matter? Can you make a difference to those people who are critically ill? As a Pharm.D, can you figure out a way to play a difference in their role? And today I've given you several ideas that you can actually kind of think about how you can make a change to not just your own lives, but the lives of others you're touching. And the other thought that I wanted to share with you was that, as an individual, you may not be able to do much, but if you're able to interact and learn and become an expert in your field, you can make a difference, because there's a need for people who know what they're talking about, who are experts and are knowledge experts, but also experts in try to coordinating with other ways to solve a problem. So today we have kind of touched about the role of a Pharm.D. We have talked about intensive care. I've given you ideas on how you can implement some of these things right away. We talked about becoming a coordinated team member with people with different areas of expertise and how you can actually do that. And I think I'm going to kind of stop there and kind of ask you all if there's any thoughts or questions, and feel free to interact with me later on. And we've been going for about 55 minutes now. And I know somebody told me if you can't deliver your message within 20 minutes, stop it because it can't absorb more. And there's a guy called Nobel Prize winning physicist called Richard Feynman who said, if you can't explain your complex concept to a third grade student, you've failed. So it's very important that your message that you're trying to get across is at the level that people can understand. And it's very important that you do your best to interact with people so you can understand what their needs are and try to deliver what they require. So I'm going to stop there, Karthik, and thank you all for listening on this Sunday morning. I hope you guys have a fun rest of the day. I'm here to answer questions and interact with you. And it's been amazing interacting with Karthik. He's done some amazing things, as we all know. And I think this is just the beginning. We have a huge task ahead of us. There is a huge need for critical care in India to improve. Cost of care has to come down. Quality of care has to improve. And there's enough people working on this. So if we work together, we can transform critical care around the world working together. Thank you all again.
Thank you, sir. Uh, so you gave me few of these ideas maybe 2 3 years back. I was just creating a platform for it to take it off, sir. So I'm happy that I found a proprietary firm recently. And my
So
goal
great.
now, we have 200 campus ambassadors, sir. I'm calling them student ambassador or campus ambassador, one from each
Okay.
college, from at least 200 colleges across India. So our next step will be to identify at least 1 or 2 members in our own family. So even that will give us at least 400 patients to work with and create their health
Absolutely.
profile, look into all their medications and optimize, and then take it to public, sir. This is what we are planning to do now, and I think we are
That's
ready to
great.
go.
That's great. Perfect. That's great.
So now, if anybody has any question, you can feel free to ask. It need not be related to healthcare. Any other question also. So I think sir will be available for 15 minutes. So please make use of that time.
Just adding my Twitter handle so you guys can check it out, and if you have questions, you can direct it there also.
Good morning, sir. This is Samiksha.
Hi.
So, could you please share us the journey of you from since start and what all were there in your journey till American board certification until now? Please, could you share with us?
Sure. Thanks. I was, thank God you didn't say share your journey from start to finish, because I'm not sure when the finish thing is. So, so essentially, so as I mentioned, so I trained in India in the Madras Medical College. I did my medicine there, and one of my inspirations was to go to America more for the intellectual freedom I thought that was available there, and I tried to did my exams during medical college itself. And it was not a common thing to do then, so I tried to do that, and left right after medical college to the US. I worked in Connecticut. Then I worked in did my fellowship training. Then I worked in a small town to kind of get my visa things all sorted out. So did that for a while. That was a very interesting experience in North Dakota, which I mentioned. Then I moved to Oregon and did my fellowship. And during all this, I was working on my MPH. I worked for a while in hospital system in California called Kaiser, which is actually a very good system where they actually integrate everything and they have a system-based practice and they have these multidisciplinary rounds and all of these good ideas which I learned from there. And I moved back to India almost 9-10 years now, and I've been doing working at Apollo Hospitals in Hyderabad. It's a really good system to work in because they have a lot of forward-thinking people right at the top, from management team, Dr. Pratap Reddy, Sangeeta Reddy, Shobna Kamineni. So they're all very forward-thinking people where they're able to get these ideas, which are international ideas, and bring it into practice. And I've been able to work using this platform because they have they have a research wing, they have a medical college, they have the pharmacy system. And we also started the remote intensive care units. I'm actually doing a lot of remote intensive care now, both for India and the US. And I'm able to actually practice what I talked about today. And we're working on that and delivering remote critical care for patients around India. So we can watch the patient and interact with them, teach them how to adjust the ventilator, for example. And also in the US, I'm doing the same thing. Even do resuscitations of patients remotely, teaching people what drugs to use in emergency. So these are things I'm doing. In addition to that, I'm interested in promoting pulmonology, which I do pulmonology and critical care, and I'm part of the American College of Chest Physicians. I'm on their board, and I actually interact with them and try. I'm on there's something called the Council of Global Governors, and they have a wing that is an executive committee for that, and I'm trying to use that to promote the concept of which are important to the American College of Chest Physicians, which is to crush lung disease. The whole philosophy is to make sure that you can actually change how patients are taken care of. And they have something called the Chest Foundation. And I was a recipient of some humanitarian awards when I was in the US. And those were actually projects where you were helping patients do things. And you can do all these healthcare projects. And the ACCP had the Chest Foundation wing where they gave these awards. And I thought this was a very humanitarian organization. And I interacted with them. And then I've been in touch with them because of this, because do a lot of patient education. In fact, if you go to the Chest Foundation website, they have information about patient-related education and helping them actually build some of these things too. That's a huge thing that you can actually all do in terms of interacting. The other area that I'm involved in now is along with remote intensive care, we have this e-access program at Apollo Hospitals where we take care of patients. And the third thing which I'm doing is something called a disease called LAM, which is lymphangioliomyomatosis. It's a rare lung disease which happens in young women. It's a genetic disease. And there's an organization in the US called the LAM Foundation. And they have clinics around the world where they accredit these clinics if you can follow a certain set of standards to manage patients with LAM. Now, interestingly, there is no clinics between Israel and China. And I started one last year through this organization. For Apollo Hospitals, we have the only LAM Foundation clinic between Israel and China. So, and we get patients from around the region. We have patients from Indonesia, Nepal, Bangladesh, etc., and India, of course, who kind of get in touch for evidence-based care. And the very interesting thing about this disease is there's a drug called sirolimus, which actually changes how patients respond, and you can actually treat patients with this. And this drug came out of a research project that the patients funded. So there's a patient foundation, the LAM Foundation. Patients actually funded the research for this project, and this got published several years ago in the New England Journal of Medicine, and sirolimus became a drug. So these are things which patients can actually transform how care is done, especially for diseases like orphan disease. And some of you can become ambassadors for the patient perspective for this, where patients actually need somebody to champion their cause. So this is kind of a quick journey. And right now I'm kind of looking at how can I transform and educate patients and providers and make a difference using my knowledge and skills and great opportunities that life has given me, the great opportunities and the privileges that life has given me in terms of making a difference to healthcare. So that's a quick summary of what's going on right now.
Yes, sir. Thank you.
So somebody has asked a question here. Satya, I need to ask, thanks for the session. Pharm.D graduate, area of interest is pharmacogenomics and personalized medicine. Future medicine, like to know about the personalized medicine starts in India from you. Okay, so personalized medicine is very active in India. In fact, several weeks ago, I got my genes analyzed to see what's going on, just to check. They did a cheek swab and they looked at my genes and they told me 1, 2, 3 things. So it's out there now. It's very available, affordable, And this is a great area for all of you to get into because there's a need to understand on a genetic basis of understanding response to drugs, for example, and also predicting what drugs it may require in the future. And this is a great area, Satya. You should actually look into that. And so the computer-based things like artificial intelligence, machine learning, those are deep learning, those are things which you can do. There's also the genetic basis of disease, which is a huge thing which is going to come up. Interacting between these two is going to happen. But there's also a huge need for bread and butter pharmacy care, making sure people take their medicine, inspiring people to take their medicine, making sure they're taking it correctly, seeing if, all of these things also need to happen. So the one thing which I didn't mention is I want to talk about aviation. Look at aviation, plane takes off, and by the way, you should all check out and follow this flight that's happening, all-women crew. See, they took off. They're taking off from San Francisco to Bangalore, longest flight by an all-women Indian crew. There's a website called Flight Radar 24. I'm just checking if they actually took off or not. Let me see here. AI 176. It's taken off just a few minutes ago, and it's right now flying over Oregon. It's going to make its way all the way across Alaska, then fly over the North Pole, close to the North Pole, fly over Russia, and then come to Bangalore on the longest flight, by the way. So the reason I bring it up is flights take off, flights land. You don't know who the pilot is. You don't know exactly who the aerosol is. You don't know who filled the petrol or the gas, aviation fuel in the plane, who loaded your luggage, who's directing the landing, the air traffic control. You have zero clue. But you trust to take off land. Healthcare needs to be the same. You need to have trust in the healthcare system, and that's something you have to build back because people have lost trust in the healthcare system. And if you take a flight, say take the flight San Francisco to India, they're going to be talking to air traffic controllers all across the way. They don't know who they are, but they're telling them, okay, I see your flight at this altitude, change direction, do these things, etc. And healthcare needs to be there. We need to guide people on how to have a safe journey. It can be done. But there's something called sigma concept, which is number of errors that you're allowed. Healthcare in India is still in the same, 1 in 1,000 error we're preventing. Advanced health systems are preventing probably the 1 in a million error. And taking care of a 1 in a million error costs that much more because you have to have systems in check for everything. In the US, for example, you have a healthcare system where your patient the door size is fixed. Then there's somebody checking the door size is fixed. Somebody checking that the guy who's checking the door size also has training to do it. Corridors in the US hospitals, about 8 tiles across. Always. And this all designed for a reason where people can get out quickly in a fire emergency, for example. So there is standard. India has the NABH, the International Joint Commission International, which our hospital, which Apollo is actually following. And you have to follow all these rules, which are important. But all of this costs money. Automate these things, etc. So this is the relation I want to talk to you about aviation. Also about your question of genomics and personalized medicine. Huge, great area to get into. Bioinformatics is a great area to get into. And again, there's a huge need for bread and butter pharmacy practice. Other questions? Anything, people have, please.
Good afternoon, sir. My name is Akshay. Sir, would you give some insight on public health, sir? How is the public health in Canada or US? How does it influence us, and how are the perspectives of how can we contribute to the community there?
Sure, great. So two questions. There's one more. I'll quickly deal with the other one and get back to you. Marina Matthews asked about adverse effect and treatment regimen. How did you deal with it and the experience? Absolutely. So there are patients who either missed a dose or got too much of a dose. There's two parts to this. One, you want to prevent harm. So somebody got double the dose of insulin than prescribed. And obviously you have to watch the sugar very closely. You have to then do what's called looking for the Swiss cheese effect. I don't know how many of you know this, but when you have an event and then you have an error, there is something called the Swiss cheese effect, which you all seen Swiss cheese, right? Cheese with holes in it. And by the way, that happens because they put a little fermenting thing and you get carbon dioxide bubbles which blow up, and that's why you get the holes in the cheese. But you need between an action and an event, which is an error, many safeguards have to go away. Meaning, suppose somebody gets prescribed insulin. Somebody has to check the dose. Someone has to see that the dose is measured correctly. then the dose has to be given correctly. Somebody is verifying that the sugar level is such that the such and such dose is needed, that there is no side effect because of the dose. So if you have errors at every level, say somebody got the wrong sugar level, got the wrong dose, gave it to the patient, absorption was appropriate and prompt, patient didn't eat, sugar dropped. So several of these holes, because if you have Swiss cheese, if you're hitting with cheese, you can't get the error to go through. But you hit that hole in the cheese, you get that error happening. So errors in treatment regimen can happen because of things like this, which is where it is important that you have a cross-check by the Pharm.D, which happens. Now, I'm going to switch this question over to the question that you asked for public health. I want to talk about public health around the world. Now, the vast majority of people are not going to end up in an ICU. The vast majority are getting these, scripts which are handwritten. My handwriting is bad. My third grade teacher told me your handwriting is bad. It hasn't changed since. So I try my best to type as much as I can. But at that situation, if you look at the prescriptions that doctors have now, the sheet of paper just has a scroll of medicine. There is no why they came there, what happened. Luckily now with telemedicine, you're getting a little more structured notes. And when you have these things happening, you're going to get errors. And public health involves not just the care for patients who are getting all these primary care issues, it may also involve advanced care, tertiary care, secondary care issues. And what we need to think about is that patients who are having in public health situations, you need to look at the common diseases like diabetes, hypertension. How do you monitor these patients and manage these patients? And how do you actually control their diseases in a very effective and evidence-based way? There are all these bundles, critical care bundles we talked about, these bundles for people with congestive heart failure that insurance companies won't pay if you don't have this patient on, say, an ACE inhibitor, for example. So in public health has that role. The other role which you asked about US and Canada, now, public health infrastructure in India is improving a lot. Say, for example, the Indian Institute of Public Health as well as the Government of India Primary Health Network, it's actually pretty good. We just have to, the scale is so huge that you need more effort to make it work. And there's a role for all of you to play in terms of improving the healthcare infrastructure, public health in India also. In US and Canada, they have a very well-advanced healthcare public system where you have these systems where there's good epidemiologic data gathering, statistical data gathering, and there's one of the journals just free of course is NMWR, Morbidity and Mortality Weekly Review. Every week, if you look at it, you should look at it, it's free of cost. If you look at it, every week they're measuring the outcomes of, I think, 30, 40 diseases. They're tracking these to see how many of these are there. And they actually put out good information very early on saying, there's a spike in this disease. Influenza, there is a flu.gov website. They're monitoring influenza around the world, around the country also. In each place, you can know how much influenza is going on so that you don't spread it. COVID, we have many such resources. So there are things like this which are going on. Public health practice is a good way to do it. Now you need to, sometimes you have to do things where you don't really are not interested, but what you need to actually do there is you have to do it because it's important. So public health is important, but you can also use public health as a stepping stone for whatever else you want to do. Many Pharm.Ds have done public health and then gotten into spaces where, say, tobacco control, public health is important. Very state governments in many places around the Canada, US need somebody who's monitoring these things. They can have a Pharm.D background. So these are some areas where you can actually play. So those are two questions that Marina and I forget your name. Sorry, you had asked about public health infrastructure.
Hello, sir. I'm Aishwarya Anand. I wanted to give the feedback on this video. Actually, a few days ago, my PG was telling me that often doctors forget the basics. That is, we should stay empathetic to the patient. We should stay more connected to the patient. Today, after listening to your session, I got to know how humble and how much you connect to the patient with the humanitarian basis. So until someone reinforces all the points you told us today, it doesn't strike into our head. Even though the points are general, the session what you gave us today is not something common to us. So thanks a lot for today's session, sir. And one more thing, I want to ask a question. That is, a patient have been put into ICU, and the patient relatives are either due to lack of awareness or to harm the patient, are not ready to agree to the treatment you are planning, but you are 100% sure that that treatment would save the patient. So you should take care of the patient. At the same place, you should also handle the medical proxy or the caretaker or someone. So how do you do that, sir?
Excellent question. Aishwarya, where are you from? Where are you calling from?
I'm from Karnataka, Mysore, sir.
Okay, very good. So, I think it's a very good question. So I'll just quickly touch on what you talked about, the empathy part. So there's good data showing that if you can listen to a patient for, I think, the first 30 seconds or something of your interaction, you can almost always solve the patient's problem. Because if you listen without interrupting for the first 30, 45 seconds, the patient will actually tell you in their own words what's going on. That's one concept. The second concept is that time is very relative, the perception of time. So if you're actually, with in the US, for example, there was a huge push to get shorter appointments with patients. They did this research study where they looked at if you actually sit down and maintain eye contact with the patient with your body language, you might be typing because you have medical records, but if you maintain eye contact, patients perceive that you've spent a lot of time with them. So in fact, if you spend 3 minutes, they feel like it's a lot of time. So if you can actually spend time with the patient, interact, that's something you can do. And just a technology point here, there are newer systems of electronic records coming in where you do your interaction with the patient without anything. There's an AI engine around you in the room, picking up your conversation, creating your note, looking at the vital signs, drafting your information. You had a ready-made note without you doing anything. So that's coming down the line very soon. Now, one of the things that I learned was it's very important to teach to learn. You have to teach somebody to learn. So what you raise is a very good point, and the brain is actually wired like that. If you tell somebody something, you reinforce your neurons to create those pathways. There's a great book I was reading recently called Atomic Habits by James Clear. Check out this book. It's a very good book where they teach you about if you make a small change every day, make a 1% change every day, at the end of the year, you're about 37% better than what you started. And if you can actually make a habit, so these two good books, 5 a.m. Club and Atomic Habits, it teaches you about how you can actually make a difference in people's lives by just changing yourself, become a better person, whatever you're doing. And I think what you raised about empathy is very important because patients really need it. It can come from anybody in the healthcare team. It doesn't have to be the doctor. It can be anyone in the healthcare team who sits down, holds the hand of the patient and says, you know what, things will be fine. Talk to the family, things will be fine. And, a lot of things are not in our control, but what is in your control is your expression of empathy and love with that patient. The other question was about how do you deal with patients who are non-compliant, who don't want to do what you're telling them to do? It's an important question because a lot of times, especially if you have various systems of care, including alternate systems of medicine, allopathic medicine, homeopathy, Ayurveda, Unani, non-traditional systems of care, faith in medicine is a critical piece which will only come with time and understanding. You have to do your best to get to the patient's level and tell them, this is my experience, this is the evidence, this is why I'm recommending you do it. You will not succeed all the time, but you can do your best in trying to explain to patients why they need to do this. But it is not an easy task. There are methods of kind of coming down to the patient's level and explaining. And I often spend time understanding where they're coming from. Oftentimes, patients will express it. Might be that they can't afford it, or they heard this from somebody else, or it might be that they're trying out some alternative therapy and they don't want to do this, or they've heard that, oh, you know what, healthcare, everyone dies if you get intubated, things like that. So there's a role for you to sit down and empathize with the patient. May not be successful all the time, unfortunately, but you can try your best to do that. And I have, prescribed treatment regimens to patients who they don't take it. The other side to the coin is there's something called the placebo effect. Sometimes not taking medicines work. And there's sometimes situations where there's a natural history of disease where things get better. And maybe they didn't need the medicine. Maybe your diagnosis is wrong and the patient is right and they didn't need the medicine. So look at the whole picture and do your best. And there are situations where you have to say, you know what, this is not reasonable. I'm going to treat it. And these are situations where the patient is being unreasonable or going to cause self-harm. So you can actually take action and take care of the patient in that sense. Thank you, Aishwarya. Akila is asking a question. Thanks for the motivational session. How can we notice and conclude some reactions due to the drug-drug interaction when they're not allowed to analyze from any sample or to perform therapeutic drug monitoring? I think there's nothing like you're not allowed to perform. You need to have an infrastructure in place to actually have a way to actually do this. So if you've not previously talked to your administration and done this, then you're not going to be able to do it. you have to do a kind of there's something called Occam's razor. Occam's razor is trying to come up with a simplest way to explain a situation, especially with somebody with multiple symptoms. How do you come down to a simplest way of explaining all of this with one explanation? And sometimes a drug-drug interaction is one way to do it. And therapeutic drug monitoring is often not available, it's expensive or not done. You're right, sometimes it might not happen, but you have to use the most likely possibility because we're all dealing in probabilities in healthcare because you're not always 100% sure exactly what's going on. And you deal with probabilities and differential diagnosis and say, this is what is going on. And let's see, Shivani, therapeutic functional pathology. Okay, so Karthik said he's going to answer that for you, Shivani. So he should probably do that later or offline or even now.
So I will do it later, sir. So
Okay,
any other
you.
questions if you have? So I think one last question, or if somebody wants to give a feedback, they can give a feedback before we close.
Sure.
Good morning, sir. This is Vaishnavi. First of all, thank you so much, sir, for this wonderful. I could say this is a motivational session rather than what we have, like the title. I could say it is more a motivational session. As per up to me, it's a big motivational session. So together, everyone achieves miraculous, sir. It's true. We have to achieve miraculous together. And knowing strengths and weaknesses are very, very important to overcome our weakness and stay strong. And we have to never stop learning because life never stops teaching. These are all the points I've noted down just because they are very, very inspiring, sir. And thank you so much, sir. Thank you is a little word, but I could extend my thank you by following your day-to-day things, what you have told during our ward rounds and during my hospital stay or whatever. Thank you so much.
Thanks, Vaishnavi. Where are you from, Vaishnavi? Where are you calling in from?
I'm from Rajahmundry, sir. I'm a person indoor. Yes, from Andhra Pradesh.
Thank you.
So
Just a couple of things in the chat network. Kirtana says thank you, and Kirtana says small doubt about integrative medicine, treating a disease, the whole body, mind, body, soul. In India, is it possible to make this change with communication? Absolutely, Kirtana, it can be done. I think it will require effort. It will require, and these are all gaps you've identified. You've identified a gap right now saying, oh, this is a problem. How do I solve it? Get together with people and say, okay, how do I solve this? How do I get together with alternate providers and say, you know what? Our goal, patient gets better. Whatever works, figure out a way to do it. Now, Yashi had also asked about role intensive care. How do you convince healthcare in charge about the same? Now, that you have to deal in. So, this is about how do you deal with personalities? How do you deal with people? So healthcare is not just about knowing what drug to give, it's about interacting with other human beings. So you have to look at conflict resolution, look at how do you dance without stepping on toes? How do you figure out that you build trust that you're in charge, that, you know what, Yashvi knows what she's talking about, she's talking about, how do you actually do that? So those are ways you can actually build and do things. Parachi says something very clearly. How much change? Okay, great. Ruby, okay, guys. Okay, great. So all this. Thank you. Thank you all. Thank you for listening. I mean, obviously it's Sunday morning, and you all have a lot of things to do, I'm sure. And do your best to do the simple things we talked about. Life is not that complicated, honestly. It's actually pretty simple. The rules of life are not very complicated. If your intention and your mission and your vision is, let me just help somebody out, the way will form itself. Your path will show.
Hi, sir. This is Akila.
Hi.
Sir, I want to give my feedback. It's really a motivation session, sir. Really, you have added some more points that where we can work more, that where the activities we can do, and all the activities you told you have been doing. Those were really inspirational for us to go ahead. And really, this is a great session, sir. Not like only talking about the critical role and patient care. You also enriched us about the activities that we can do to improve the patient care. Thank you so much for the session, sir.
Absolutely. Thank you.
Yeah, thank you, sir. So definitely we will try to put at least few aspects which you raised and send you a report on the outcome of this session, sir. So we will definitely do that.
Absolutely. Perfect. Thank you again, Karthik, for inviting me. And great job that you're doing. Do your best. Just make a difference to what people are doing. All right.
Thank you, sir.
Thank you, guys.
Bye, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.